All right, this case is of a 50-year-old female with chest pain and shortness of breath. This case comes from Dr. Ryan Gombosh. He's a good dude, one of our attendings. His wife is also one of our attendings. And I'd like to take the time to propose that the plural of Gombosh should be Gombai. Like cactus becomes cacti. So when you see those two together, be like, look at those Gombai. Like, don't say Gombashes. We're not fools. Let's use our minds here. All right, so remember the value of any EKG depends on your pretest probability, and we get the pretest probability from the history. This is a 50-year-old female who comes in for chest pain and shortness of breath, says she's short of breath yesterday and progressively worsened since then, complains of discomfort in her chest, denies nausea and vomiting, past medical history of sleep apnea, had right knee surgery in March, presented hypoxic, complaining of dizziness, denies any cardiac history, denies a history of pulmonary embolism. All right. So the pretest probability for this patient is concerning for a pulmonary embolism, right? Like number one, she presented hypoxic, okay? Number two, she is complaining of shortness of breath, okay? Number three, she recently had knee surgery, okay? And number four, she had recent travel. The history says that her surgery was in March. Dr. Gombosh saw her maybe like a month or two after that, okay? So Dr. Gombosh gets her previous EKG for comparison's sake. As usual, pause your computer, look at the EKG, think about what your findings are, and also think about what your interpretation is. Remember, the definition of interpretation is the action of explaining the meaning of something. All right, so here's my overall interpretation. Number one, the rate I would say is normal. Okay, for the rhythm, I would say is sinus, okay? For the axis, it's up in 1 in AVF, so normal. For the intervals, the things we're looking for is prolongation of the QTC or widening of the QRS, which I see neither of those. The last thing we're looking at is the ST segment. Specifically, we're looking for any J-point deviation from the PR segment, and I don't see any really significant J-point deviation. My overall interpretation for this EKG is it's non-diagnostic and non-specific. The interesting thing on here to talk about is, well, what the rhythm is, okay? So remember, this whole thing at the bottom here is the rhythm strip, okay? And the rhythm strip is always either lead 2 or V2, because those are the best place to see P waves at. And for the rhythm strip, my recommendation is to read it just like a book, read it from left to right. And the question is there 1 P for every QRS? If the answer is yes, it's sinus and you're done. If we look closely at this rhythm strip, however, we'll notice that there's a couple different P wave morphologies, okay? We have this P wave morphology, which is similar to this one, okay? A little bit tall, relatively smooth, no notching, and then we have this different P wave morphology here, which is broader, flat, and has a notch in it as well. Okay, you can see the same thing down here. Okay, there's that second P wave morphology. You can see it also reflected up here in lead 1, how we have 2 different P wave morphologies, correct? And remember, vertically, all these beats are the same, so this makes sense that this P wave abnormality lines up with this one. Okay, so in my opinion, this is still a sinus rhythm. Is it a normal sinus rhythm? No. I would qualify this as a wandering atrial pacemaker or an ectopic atrial pacemaker. The most likely cause for that is underlying lung disease. Is this a pathologic process? No. Remember the difference between wandering atrial pacemaker and multifocal atrial tachycardia. MAT has more than 2 wave morphologies and is tachycardic. This one is not MAT because number 1, it's not tachycardic, and number 2, we only have 2 different P wave morphologies. All right, here's the EKG when Dr. Gombosh saw her. Same thing, pause the EKG, write down your findings, and think about what your interpretation is. So here's what I see. Number 1, I do see sinus rhythm. We do have, if you look closely down here at the rhythm strip, same thing as usual, different P wave morphologies. We have this smaller one and this taller one, and then this kind of like broad notched one. Again, not tachycardic, so not MAT. The axis is up in 1 and up in AVF, so it's normal. For the intervals, I see no prolongation of the QTC or the QRS. The main abnormality here is the ST segments. Okay, the first thing that draws my eye is the precordial leads. Okay, When we look up here at V1, we do see ST segment elevation, okay? Remember to always compare the J point to the PR segment. Here's the J point, here's the PR segment. We see about 2.5 millimeters of elevation. Same issue here in V2, okay? If you'll notice, we have almost an incomplete right bundle branch block and RR prime in the precordial leads. And again, when we look at the J point and compare it to the PR segment, we see about 3.5 to 4 millimeters of ST elevation there. If we look over here at the lateral leads, we do see some J point depression. Here in lead 4, there's the J point, there's the PR segment, maybe 0.5 to 1 millimeter. Same thing in V5 and V6. Yeah, I mean, you can see it better in V6. When we look at this J point here to the PR segment, we see about maybe 2 to 3 millimeters of J point depression. And same thing up here in AVR. Okay, we do see some J point elevation. We see the J point is up from the PR segment approximately 1 millimeter. Okay, so Dr. Gombash, rightly so, was worried about an infarct, but being the astute physician he knows we don't treat an EKG retuted patient. With her pretest probability concerning for a pulmonary embolism with the recent travel, surgery, and hypoxia, he worked her up for both. So her troponin, I mean, obviously was elevated at 0.78. Her D-dimer was elevated, but I want you to note, like, he didn't base his decision-making on the D-dimer. Like, when the patient came in, his decision point was, I'm going to send her right to the CT scanner because it's either an infarct or a PE. And here's her CT scan, okay? As you can see, okay, there's a large bilateral clot burden, okay? We got clots over here. We got clots over here. This isn't the best picture, but the septum here is not necessarily bowing, but the right atrium up here is borderline the same size as the left atrium. So there's definitely, in my opinion, signs of heart strain, but it's difficult to tell just based on this one CT scan. So the short of the story here is not all ST elevation is an infarct. Other things can cause ST elevation, and a PE is one of the known ones to cause that. So let's look at the literature. Okay, here's like a case report that concerns the same thing. This was a patient that presented for concerning signs of an infarct, but turns out to be a pulmonary embolism. Okay, so when we look at this EKG, same thing. If you want to pause, write down your findings and interpretation. Number 1, we do have sinus tachycardia. Okay. Number 2, if you'll notice, we do have a right axis deviation. Okay, it's up in AVF and it's down in lead 1. Okay, that's a right axis deviation, which should always make you concerned for a pulmonary infarct. Here in lead 3, we don't necessarily have a Q wave, but we do have T wave inversions in lead 3. Okay, the S1Q3 T3 is a very sloppy sign for a pulmonary embolism, but it's not something you can ignore. The main abnormalities here are on the precordial leads. When we look at the precordial leads, specifically V2 and V3, the appearance of these leads are concerning for what's called a type 2 Wellens. Okay, there's 2 types of Wellens, and Wellens is critical stenosis of the proximal LAD, and the morphology is either number 1, a biphasic T wave in V2 or V3, or number 2, which we have here, a deep inverted T wave. And again, those are signs of critical stenosis of the LAD. We do have ST wave abnormalities over here in V4 and V5. Okay. There's no real J point deviation in 4 and 5. There's the PR segment, there's the J point, but we do have this deep T wave inversions here. Okay, and also this biphasic T wave as well. Again, remember, we don't treat an EKG, we treat a patient, and what I would do with this EKG depends on what the patient is presenting for. If they were high risk for coronary artery disease and had stories concerning for ischemia, I would proceed down the pathway for coronary artery disease, but this person, again, had high pretest probability for a pulmonary embolism. Here's their CT scan, again, which shows bilateral PEs with heart strain. Another case from the literature, okay? Again, pause your EKG, look at this one, think about what your findings are and what your interpretation is. This EKG is wrought with abnormalities. For my interpretation, I do think it's a sinus rhythm. Okay, down here in the rhythm strip, I do see 1P for every QRS. This is maybe like a first-degree AV block. But again, in my opinion, I don't really care about a first-degree AV block because no one's ever died from a first-degree AV block. Number 2, the rate, I'd say it's normal. The axis is, for this one, I would say left axis. Okay, it's kind of tricky. Okay, up here in these leads, remember vertically, like all these beats are the same. Okay, so when we look at this lead in lead 1, we do notice there's two different morphologies. We have this morphology right here, which is wide and abnormal and downward, and then we have this morphology, which is wide, abnormal, and upward. So in determining the axis, remember we can extrapolate out which these beats are, okay? These 3 beats are the same as these 3 beats, are the same as these 3 beats. So we know that this one right here, okay, again, which is the same as this beat, which is the same as this beat, is the native beat, okay, which corresponds with this 3rd beat in AVF. So the native beat is down in 1, or sorry, it's up in 1 and down in AVF, so I would say it's left axis deviation. Another interesting thing to note, again, on these native beats, specifically, specifically these ones here, okay, you'll notice that it's down in 2, 3, and AVF, and it's upright in AVL and lead 1. Okay, so that's consistent with the left anterior fascicular block. If we look over here in the precordial leads, we'll notice that there is a wide QRS and it's upright, mostly in V1 and V2, so that's consistent with a right bundle branch block. So we have a new onset bifascicular block in this case. The other thing that you'll notice is we have significant J-point deviation in multiple leads, okay? You can see it best here in lead 3. Okay, the J-point is right here, the PR segment is right here. We have about 5 millimeters of elevation. Same issue up here in V2. Here's the J-point, here's the PR segment, 2 to 3 millimeters of elevation. The same issue up in V1, as well as AVR, okay? Again, with bundle branch blocks, it's easy to lose sight of the J-point. We know all these beats are the same, so the J-point here in V2 is the same up here in V1. So you can clearly see there's about 4 millimeters of J-point elevation in AVR, and the same issue over here, in V1, the same issue over in AVR. So again, in the proper clinical setting, this is highly concerning for an infarct, correct? We have J-point deviation in contiguous leads. We have a new onset bifascicular block, as we discussed in previous cases, is concerning. But guess what? This wasn't an infarct. This was a pulmonary embolism. All right. Same thing from the literature, and we have the same issue here. Okay. Number 1, we have sinus tachycardia. Number 2, we have pretty significant S wave in lead 1. Okay, concerning for right axis deviation. We have a Q wave in lead 3 and T wave inversion in lead 3. Remember, S1Q3 T3 is not very specific. It's a sloppy finding. You can't always base that for a pulmonary embolism. If you'll also notice, we have a complete right bundle branch block with a wide QRS, and it's upright in the precordial leads. Again, remember, for a right bundle branch block, we would not expect to see axis deviation. So anytime you see axis deviation with a right bundle branch block, that should make you concerned for some type of pathology. Of note, we also see significant J-point deviation in multiple leads, okay? 1 and 2 is AVR and V1. Up here in AVR, there's the J-point, there's the PR segment, 3 to 4 millimeters of elevation. Same issues up here in V1. Here's the J-point, here's the PR segment, a few millimeters of elevation. And you can see wicked J-point depression in AVL, right? There's the J-point, there's the PR segment. We got more than 5 millimeters of J-point depression, and I'm always going on and on and on about J-point depression and inversions in AVL being a sign of acute coronary syndrome. And we have the same issue up here in lead 1. Here's the J-point, here's the PR segment, significant depression approaching 5 millimeters. But guess what? This was not a infarct either. This was a pulmonary embolism. Same thing, more cases from the literature. We have the same issues here, okay? We have an incomplete right bundle branch block appearance in the precordial leads with J-point deviation. Okay, we have maybe a 0.5 to 1 millimeter in V1. Or V2. You can see it better over here, and the same issues up here in V1 and AVR as well. Okay, again, maybe 1 millimeters of J-point elevation in AVR. Same thing here in V1. Also out in the lateral leads, we have J-point depression. Correct. Here's the J-point, here's the PR segment, maybe 1 millimeter. Same issues in V5. Here's the J-point, here's the PR segment, we have depression. And again, look at AVL. Okay, this is what I'm always talking about. Number one, we have inversion. Okay, number two, we have J-point depression, maybe like 1 millimeter. And number three, look at the linearity of this ST segment. Those are always the things I'm always going on and on and on again about coronary disease. But in this case, it was from pulmonary embolism, sending up here in lead one. All right, linearity of the ST segment and J-point depression. But guess what? This was not an infarct. This was a pulmonary embolism. This goes on to highlight you don't treat an EKG, you treat a patient, and the value of any EKG depends on your pretest probability. Here's the imaging from that case that shows bilateral PEs with heavy burden. Another case from the literature, okay, and same issues here. If you'll notice, we have this recurring pattern, okay? It's often either a right bundle or incomplete right bundle branch block appearance with precordial and or AVR elevation, right? Like here in V2, there's the J point, there's the PR segment, 2 to 3 millimeters of elevation. Same thing up here, maybe like 1 millimeter, and very obvious here in V3. There's the J point, there's the PR segment. Totally concerning for an infarct, but guess what? It was not an infarct, it was a pulmonary embolism. Same thing with this case. And again, if you look through, we see multiple abnormalities that could be concerning for an infarct in the proper pattern. Number one, we have J-point deviation in 2, 3. There's the J-point, there's the PR segment, there's the J-point, there's the PR segment. Same issue here in lead 3. We have J-point elevation from the PR segment. Again, could be concerning for an infarct in the proper setting, but this was not an infarct, this was a pulmonary embolism. So that's the short of the story, okay? The teaching points for this one, okay, is number one, okay? Not all ST elevation is an infarct, okay? ST elevation can be from a PE, okay? Number two, like we talked about before, you don't treat an EKG, you treat a patient. And number three is the value of any EKG depends on your pretest probability. Like for this case, we saw multiple EKGs, which could be concerning for an infarct, but they weren't. They all turned out to be large PEs with a large clot burden. That's all I got for this case. Hope you enjoyed it. Also, I hope you enjoyed my writing thing. I'm not too good at it, but at least I'm learning how to do this. Any questions, ask me in real life. Peace, I'm out.